Vamsi, one thing we still haven't squarely addressed is, I think you nicely, intuitively described how to identify risk, and you use data to do it. So we can figure out who's at high risk. But who should pull the trigger still? Should it be the primary care physician, or should it still be a cardiologist or vascular medicine specialist who then, lets the primary care physician know of the rationale, know to watch for bleeding, know to watch for other sorts of issues?
I think we have such, even amongst us, we have such different practices. We have a universal healthcare system. We have, we have 2 university systems, and then a large Catholic-based system. And so I think the system is really going to help define what's the best practice for that area. And so I think, for example, if it's a multi-specialty group where primary care providers are in the same area as the cardiologist, I think in those type of areas, I think a lot of the primary care physicians will feel very comfortable prescribing it. I think in our current practices where primary care providers aren't getting a lot of exposure to their cardiologist or whatnot, I think there's a lot of angst in the community for patients. They're not afraid of the data. They like the data, but they're afraid of the bleeding. And they're like, who's responsible if there's a negative outcome? And so that's really some of the feedback I get from some of my primary care providers. Luckily, I've been able to do a lot of talks and education for them to help them understand that it's actually quite simple. A majority of our patients in our South Austin area are high risk, and so it's really who shouldn't get it. And so helping them identify those things, but I really think it's the system in play. I will say what I've really strongly went after, and it's done really well, is I'm head of the wound care area in South Austin, and so the data, especially in PAD and critical limb ischemia, where there's really not great guidelines outside of some hypertension therapy, some statin and aspirin, there's really not a lot out there. And now we have a therapeutic option that has reduction of limb amputation, reduction in revascularization that we have not seen in any other choice. These are really clear reasons that we're trying to save a limb is one of the most important things. And so I think from that standpoint, I've been able to get a lot of even podiatrists and local wound care people to start prescribing it because of the end goal of what we're trying to do.
You reminded me, I think you spoke quite eloquently about the stroke reduction, but there was also an important reduction in peripheral events. Do you want to just expand on the exact findings?
Yes, so, and this goes back to your comment earlier about Dr. Narula's work, but in COMPASS we found that the reduction in coronary events was of a magnitude that was similar to that seen in ATLAS. So there's no question that this combination works in coronary disease. The treatment effect perhaps is a little more modest in the coronary circulation, but there was this very big reduction in stroke we've talked about, a 49% reduction in ischemic stroke, and a reduction in peripheral acute limb events of a similar magnitude, around a halving of the risk of acute limb ischemia and of amputation. It's really an unprecedented reduction in these very serious events. And for the vascular patient who's got peripheral artery disease, this is a compelling rationale to continue this treatment.
And who does that in Canada, by the way? What sort of physician does that fall to?
Well, in Canada, it is probably like elsewhere. It's a bit of a mix, but internists play a big role. There are some vascular specialists, family physicians. And this is also why I think, while family physicians may be cautious about this, this is going to become their responsibility, because there is no way that the specialist clinics can handle all this.
Yeah, I would say the same. I mean, I guess it is going to be system-based for sure, but another way of thinking about it is, if we didn't talk about this disease state for a second, I said somebody has atrial fibrillation and you're going to anticoagulate the patient. Are you sending them to an electrophysiologist to make that decision? You're certainly not sending them to a cardiologist anymore. You're making that decision. And the bleeding risk, one could argue, is not smaller. It's larger. It's that you're worried about a stroke. Now, I just told you that this patient has a 50% reduction in stroke and a 50% reduction in limb events if they have vascular disease, or even if they don't. So I think that it is really, I agree with you, because the family practice doctors and our own primary care doctors have said they have to get comfortable with it. The bleeding has to be managed. The dose is lower, but the magnitude's pretty powerful. And if you had these high-risk patients, I would be saying you should feel comfortable at least having the conversation or starting to think about which patients might get that. Eventually, it'll be like dual antiplatelet therapy. When that first started, it was very much a, oh boy, cardiology better tell us about these, and that got me thinking about my two antiplatelet therapies. But you can imagine that that's going to diffuse and will become useful.
And this comes, it brings us to like the whole greater point of all these risk reduction therapies that we currently have available. We have many, we have these new anti-diabetic drugs, and so, I heavily believe in the data on these SLG2 and GLP-1 agonists, and yet the cardiologists I speak to say, well, that's not my responsibility. And I'm like, but the data shows stroke reduction, shows MI, there's a 3-point MACE outcome, and now, we have credence data to show that there's even renal protection, heart failure, so whose responsibility is it? Comes back to the point of, I think there's a lot of great things out there, and we have to prioritize for each patient. Maybe like we have time to say, hey, these 2 things we're going to focus on during this visit. I think what's becoming challenging is who takes responsibility for it. And I think the better we can kind of organize as societies of saying these are guidelines, these are the class 1A, 1B indications that we should be utilizing it. I think the easier it's going to be to say, hey, we should just implement this in our system.
Well, I think the more eyes on the patient, the better. If we're talking about high-risk patients, perhaps not very low-risk patients, that might lead to just unnecessary testing. But in the high-risk and very high-risk patient, whose responsibility asked is the SGLT2 inhibitor, for example. It could be primary care, it could be cardiology, it could be nephrology, it could be endocrinology. I think it's all their responsibility because they're all going to see patients at different times in different stages of their disease projection. And I think that with respect to SGLT2 inhibitors in particular, there's going to be an uptake among cardiologists in using these agents. It's already starting where there's a lot more cardiology comfort with it, certainly in primary care.
It's taken a longer time, given, the data sets have been available, for some time.
Yeah,
and the uptake has been.
I think one of our messages, and we all, I live in the South of the United States, so change is hard sometimes, right? It takes a while. I'm probably sure if the United States in general or all of our countries. But if you think about in this year, 2019 was the first year that new starts for anticoagulation for atrial fibrillation were greater than 50% novel oral anticoagulants or non-vitamin K anticoagulants. Okay, so 2019, greater than 50% of the people worldwide are getting the new therapies, which by and large, all 4 therapies reduce stroke, or at least is similar in rates of stroke, but reduced intracranial hemorrhage, reduced fatal bleeding. Had signals towards benefits, and before they started, we all said, oh, but wouldn't it be nice if you didn't have to finger prick and get a drug? Okay. The data started coming out in 2009, 2010. 10 years, yep. So 10 years of lives that could have been affected. So Compass is now out. That's certainly not going to be for everyone, but I would just say it's another example with SGLT2 where most of what we're doing here today and other things is to try to reduce that gap, that comfort from saying there's now evidence, you're going to have to try it in someone. How do you try it and get comfort in it and then move on?
But I think it should be much faster
of
with the Compass thing than at least with atrial fibrillation.
Sure.
You had warfarin, so you had something that worked pretty well. No question, it still took a long time. But with the Compass regimen, especially for some of these super high-risk patients,
certainly these limb patients, carotid patients, limb patients, polyvascular patients, I would argue right now you're right. We don't have a lot of other things, and unfortunately, whether it's amputation or procedures, every year, I say this in our state, every year in the United States we have more amputations than all the wars combined and all the other things. So our opportunity.
That's a very sobering statement when you put it that way.
So there's an opportunity to make a difference in things people care a lot about.